Okay, so here's our part 4 of our childhood growth and development questions. Question 16 gives us a 4-year-old girl presenting with her mother for a well child checkup. There are presently no complaints. However, she has been seen in the ED 3 times over the past year, each time for bone fractures. Physical exam reveals a friendly, talkative girl, appropriate behavior for age. There's knobbing of both wrists and bumps along the costochondral junctions. Her diet is vegan and she drinks soy milk and water primarily. Labs are ordered, BMP is normal. Calcium is 8.1, phosphate is 2.0, magnesium is 2.1. Urinary calcium is low, urine magnesium is high. 25 hydroxy vitamin D and calcitriol levels are both low. Which of the following is the most likely cause of this girl's presentation? A. Fanconi syndrome. B. X-linked hypophosphatemic rickets. C. Vitamin D deficiency rickets. D. Vitamin D dependency or vitamin D dependent rickets type 1. Or E. Vitamin D dependent rickets type 2. All right, an answer here is C. Vitamin D deficiency rickets. All right, what do we have? Okay, I added one thing. I probably shouldn't have done that. We have a negative urinary protein. Okay, whatever. That's not really going to play a big role here. How do we know that this is vitamin D deficiency rickets? Well, we have a diet here that's vegan. She drinks soy milk. So what do you not get when you have a vegan diet? You're not having animal products. And vitamin D pretty much always comes in animal products. Yes, you can take a vitamin D supplement, but we don't see that in this patient. So a vegan diet and soy milk, those are both risks for vitamin D deficiency. And we know that this child has rickets based on the presentation. You have that knobbing of the wrists. You have that ricketic rosary on the costochondral junctions. And then you also have this diet, which is consistent with vitamin D deficiency rickets, low dietary intake of vitamin D. It is possible that you can get vitamin D deficiency rickets from something like cystic fibrosis or malabsorption or celiac disease, but we don't see that in this patient. And that would also be considered vitamin D deficiency rickets as well, but it would be secondary to malabsorption. So what are all these other things? So Fanconi syndrome is a defect of the proximal tubule. You'll see metabolic acidosis present. We don't see that. The BMP is normal. And this also leads to proteinuria. That's why I included the negative urinary protein here. So this is due to a kidney problem. And we don't have that here. X-linked hypophosphatemic rickets is a genetic disorder. You have an increased fibroblast growth factor 23. What that serves to do is inhibit 1-hydroxylase. And 1-hydroxylase is important for converting 25-hydroxy vitamin D over to calcitriol. And calcitriol is the active form of vitamin D. So if you don't have, or if you have an inhibition of 1-hydroxylase, you'll have a high 25-hydroxy vitamin D, but a low calcitriol. There'll be a lack of negative feedback, and you'll have all this 25-hydroxy vitamin D, but you can't convert it into calcitriol. Otherwise, though, the profile is going to look very similar to vitamin D deficiency rickets, because essentially you do have a vitamin D deficiency. You have a deficiency of calcitriol, and that's the active vitamin D. But rather than having low levels of both 25-hydroxy vitamin D and low levels of calcitriol, you'll actually have a high level of 25-hydroxy vitamin D because you have a metabolic block. Vitamin D dependent rickets type 1 is a 1-hydroxylase deficiency. So that looks a lot like X-linked hypophosphatemic rickets. And so you can do genetic testing. But remember that vitamin D dependent rickets, type 1 and type 2 for that matter, these are both autosomal recessive diseases. So you can see this in little girls. With X-linked hypophosphatemic rickets, it's pretty much only going to be in boys. And then vitamin D dependent rickets type 2 is a calcitriol receptor mutation. And so this is going to look similar to vitamin D deficiency. It's autosomal recessive. It'll look also similar sort of to Fanconi syndrome in some ways. But what you have here is a lack of calcitriol receptor or a mutation. And so there's no negative feedback. That's going to lead to high calcitriol levels. But those calcitriol levels, regardless of the fact that they're high, the calcitriol cannot act. And so because it can't act, you're going to have a low serum calcium. So you would expect if you had a high calcitriol level that you would have plenty of vitamin D action going on, but you don't have that. Your profile, your metabolic profile, is going to look like vitamin D deficiency, but your vitamin D levels are going to look perfectly normal, if not high. So that would be the vitamin D dependent rickets type 2. So I got this all sort of laid out for you. You can print this out if you want, or take a screenshot or something. So vitamin D deficiency, the pathophysiology here is low dietary vitamin D or malabsorption, as its name implies. Vitamin D dependent rickets type 1 is an autosomal recessive disease where you have low or absent 1-hydroxylase, and therefore you cannot make calcitriol. Vitamin D dependent rickets type 2 is also autosomal recessive. In this case, you have a calcitriol receptor mutation. You can't respond to calcitriol. So the difference between these two is they're both going to look like vitamin D deficiencies, but the difference is going to be in those vitamin D levels. With type 1, you'll have a high amount of 25 hydroxy vitamin D, but low calcitriol. With type 2, you'll have high levels of calcitriol. Hypocalcemic rickets comes from a low dietary calcium. That's going to cause a high PTH, which leads to demineralization. Important, though, with this hypocalcemic rickets, because you get demineralization because of the high PTH, your serum calcium will probably be in the low normal range because you're demineralizing your bone, and so you're getting your calcium that way. But you're getting rickets from the demineralization. And if you took a PTH, that would be high. Renal osteomalacia is due to renal calcium wasting. There are other things that are behind this too. Remember that your 1-hydroxylase is in your kidneys, and so you can have low 1-hydroxylase levels. Something that's really going to be obvious with this is that you're going to have a high creatinine. That shows that you have a renal issue. And then you can also see things such as a high urinary calcium and a low urinary phosphate, and that's going to result in a hyperphosphatemia. We see all those things in any kind of renal failure. X-linked hypophosphatemic rickets is going to be a high FGF23, which causes an increased phosphate excretion. Also inhibits 1-hydroxylase, and so you're not going to get the calcitriol levels that you should have. Remember also that this will be typically seen in little boys. So if you see a little girl who has rickets, I never like to say always, but you can pretty much always cross this out. Unless both parents have a history of X-linked hypophosphatemic rickets in their family, or you have a little girl, I suppose, with Turner syndrome. Then finally we have the HHRH. This is autosomal recessive. This is due to a sodium phosphate transporter defect, increases phosphate excretion. So when there's calcium or phosphate wasting, usually there's a pathophysiology in the kidneys of some sort. The serum calcium will often be normal because there's bone demineralization. So this can be things like renal osteomalacia, X-linked hypophosphatemic rickets, and HHRH. Another thing to look at is your vitamin D levels. So with vitamin D deficiency, typically your 25 D and your calcitriol levels will both be low. With vitamin D deficiency rickets type 1, your calcitriol level will be low because you can't make calcitriol. With vitamin D deficiency rickets type 2, your calcitriol level will typically be high because the calcitriol cannot work, and you're just producing a bunch of it, but all in vain. So this isn't perfect, but this is typically how these will present as far as labs. If you know the pathophysiology behind it, so you know this stuff, that will really help you with your labs. Some hints you can take out of this is the history. So obviously, if the patient has any kind of family history of any of these issues, that can certainly point towards one of these genetic problems, such as VDDR, XLHR, HHRH. If there's a dietary issue, so if they're, like in this patient, they're not getting enough dietary vitamin D, that points you towards vitamin D deficiency rickets or possibly hypocalcemic rickets. And then the vitamin D levels, that's probably going to be the most helpful because that can help you parse out some of these genetic causes or vitamin D deficiency. And then creatinine is a very obvious, if it's elevated, that's a very obvious sign of renal failure. And if there's renal failure and rickets, that's probably a renal osteomalacia. Question 17. A 17-year-old boy presents to your clinic complaining of difficulty seeing while driving at night. He complains that he nearly got into an accident last night, which prompted him to come in. On review of symptoms, he describes ongoing mild abdominal pain with occasional diarrhea. He's 5 foot 10 inches tall and weighs 125 pounds, which is a BMI of 17.9. Physical exam is significant for abdominal tenderness, generalized mild pallor, and a small white spot on the left conjunctiva, as well as dry, scaly patches on the elbows. BMP, LFTs, and TSH are normal. CBC reveals microcytic anemia. Stool studies are remarkable for fecal fat, negative for RBCs. Anti-tissue transglutaminase is positive. Which of the following is most likely the diagnosis in this patient? A, vitamin D deficiency due to malabsorption. B, vitamin A deficiency due to malabsorption. C, systemic Crohn's disease. D, Reiter syndrome. Or E, macular degeneration. All right, answer to this one is B, vitamin A deficiency due to malabsorption. So let's look at this patient again here. So we have a problem with driving at night. What does that tell you? This patient may have night blindness, nyctalopia. And so that is something to consider. We also see issues with the GI tract, which look a lot like malabsorption for several reasons. One, you have occasional diarrhea. If you asked them, it would probably be stools that float in the toilet, as well as very, very, very abnormally bad smelling stools. I never like that description, but that's how the USMLE likes to give it to you. It's like, stool always smells bad, but these would be particularly bad smelling stools. You also, when you do your stool studies, which is typically a good thing to do anytime you have chronic diarrhea, it's remarkable for fecal fat. And so that is that's telling you that indeed you do have a malabsorption issue here. And that's going to be a risk factor for vitamin deficiency, particularly A, D, E, and K. What we also see here that points us towards malabsorption is the fact that this 17-year-old is very thin. He's got a BMI of 17.9, which is below the normal range. 5 foot 10, 125 pounds. You will see that this kid is very, very thin. And so when you have another constellation, when you have diarrhea and thin, that's going to point you towards malabsorption as well. Other things that point us towards vitamin A deficiency is the pallor, and then this Beteau spot, which is a small white spot on the conjunctiva. That's a sign of vitamin A deficiency, and then these dry, scaly plaques on the elbows. So why is this not vitamin D deficiency? Well, vitamin D deficiency will typically present like that last patient we had, where you've got bony abnormalities. You've got calcium deficiency. We don't see that here. Systemic Crohn's disease. This also can cause malabsorption. But what do we not have with this patient that we would see in Crohn's disease? We would typically, with Crohn's disease, see red blood cells in the stool, or certainly white blood cells in the stool. That's not present. So we can pretty much cross that out. Reiter syndrome. What is Reiter syndrome? It is reactive arthritis where you can't see, can't pee, can't climb a tree. So there's going to be a history of an STD. There's going to be, yes, difficulty seeing, but there's also going to be bone pain, and we do not see bone/joint pain in this patient. So Reiter syndrome is unlikely. Macular degeneration, that's pretty obviously wrong. That tends to happen in older patients, and they're not going to have all these other signs as well. And usually with macular degeneration, it's going to be, you're going to have visual symptoms during the day as well. So this is vitamin A deficiency due to malabsorption. I gave you a really nice hint here that this is malabsorption. The anti-TTG is positive. And what do we see anti-TTG positive in? We see that in celiac disease. And celiac disease leads to abdominal pain, malabsorption, diarrhea, and with the malabsorption, you get the vitamin A deficiency, which leads to all this other stuff. So vitamin A deficiency, most obvious symptom is reduced integrity of epithelial tissues, and that leads to all of these things that we see. So abnormal, or the normal mucus-secreting intestinal epithelium will lose integrity, become diseased, which can result in infection, malabsorption, diarrhea. The normal mucus-secreting respiratory tract will lose its ability to clear inhaled pathogens and toxicants, which can result in bronchial obstruction and other respiratory sequelae. Loss of integrity of the bladder epithelium can lead to pyuria and hematuria. The keratotic squamous metaplasia that you can get is what causes the changes in your skin, which is known as keratosis pilaris. That was what we saw in his elbows. And then you can also get it on your cornea, which causes xerophthalmia, and then on the conjunctiva, which is the Bateau spots, and that's those little white spots we saw in the conjunctiva. And then changes in other tissue, such as the GU system, the pancreas, vagina, can predispose to infection. Also, remember that vitamin A is a constituent in the rods and cones, and so this deficiency can also slow adaptation to the dark due to loss of pigments in the rods. Ultimately, this is going to lead to night blindness, and total blindness can occur due to destruction of the retinal pigment epithelium. So this is what we're seeing in this kid. We're also seeing the Bateau spots and the diarrhea. So this is that squamous rash, the keratosis pilaris. And I think that's Latin for just keratinizing or hardening of the pila, which is part of the hair. This is a Bateau spot. So the management for this patient is going to be, we got a diagnosis, symptomatic vitamin A deficiency secondary to malabsorption from a primary diagnosis of celiac disease. The treatment plan is going to be to investigate for other vitamin deficiencies, particularly your fat-soluble vitamins. Likely not the problem in this patient, but for completion's sake, we want to look for vitamin deficiencies. So you can get vitamin D, E, and K levels. Intramuscular vitamin A administration is going to be preferable in this patient in the near term because with celiac disease, it takes some time for those intestines to get back to normal. So you want to give the patient vitamin A intramuscularly because he still is going to have malabsorption even when he goes on a gluten-free diet. It's going to take a while for those intestines to get back to normal to where he can absorb those vitamins. So you'll give him an intramuscular administration, start him on a gluten-free diet. Once the diarrhea and the GI symptoms go away, then he can take vitamin A supplements. Or may not even need vitamin A supplements. He can just maybe absorb the vitamin A he gets in his diet. But you need to resolve the malabsorption. And so that's going to be done with this patient on a gluten-free diet. You want to consult ophthalmology just because he's got a Bateau spot and the night blindness. You want to consult gastroenterology because he's got celiac disease, and then a nutritionist will help with establishing a gluten-free diet. I want to tell you something with a gluten-free diet. When you have a patient with celiac disease, this is not as simple as just avoiding bread and things that obviously have wheat in them, like beer, bread, pasta. There is gluten in so many different things. I have a friend who's got celiac disease, and I didn't even realize this until he told me all about how he has to avoid these things, even things like sauces, like barbecue sauce or ketchup, or things that are candy coated. That can have gluten in it. We put gluten in all sorts of things, and so it's very difficult to get to establish a gluten-free diet. And so that's why it's good to be in consult with a nutritionist, especially if you can, a nutritionist who has experience with patients with celiac disease. Question 18. A first-time mother presents with her 13-month-old daughter because she has not yet walked. Mother read in a parenting magazine that baby should be walking by 12 months of age on average. History is insignificant, but for hip dystocia, which was corrected with a Pavlik harness, she presently weighs 25.2 pounds. Her birth weight was 8 pounds 2 ounces. On physical exam, child appears to be grossly normal. She shows affection and preference for her mother, who she says mama to when you remove her from her arms. While you are talking to the mother, the child crawls and explores the room. Which of the following is best next step in management? A. Reassurance, follow-up at 15 months. B. AP lateral and frog leg radiographs of the hips. C. Knee radiographs. D. Nutritional assessment. E. Assessment by a developmental pediatrician. All right, the answer to this one is A, reassurance. So this happens a lot. The very involved parents, which is good, all parents should be involved, but particularly the first-time parents who've never raised a child before, they'll read these parenting magazines or these books and sometimes can give not very good information, like something like baby should be walking by 12 months of age. What that tells a parent is that if my kid's not walking by 12 months of age, something's wrong. And so they bring their kid into the clinic, and what you know is that there is a range of normal, not a date that's normal. Kid doesn't wake up on their first birthday magically able to walk. What happens is there's a range, and if they're outside of that range, there may be something wrong. And so 12 months of age is the very beginning of that range. And so we don't consider it to be abnormal until they hit 15 months of age and they're not walking. And we look at everything else in this baby, and it's completely normal. So you have a history of hip dystocia. That was all corrected. So that's good. You have a child that weighs 25 pounds at 13 months. So by 12 months, the child should triple their weight. And so baby was born at 8 pounds 2 ounces. Triple that, that's 24 pounds 6 ounces. This baby weighs 25.2 pounds. So that's good. We don't think there's any nutritional issues here based on this information. You look at the physical exam, grossly normal. So you got a baby that shows affection, preference towards the mother, which shows that this is probably a good mother, takes care of baby. She says mama, which is good. Baby's saying words, although that could be monosyllabic babbling, but that's good. And the fact that she's associating mama with her mother points to the fact that that's probably a word, not just babbling. And then while you're talking to the mother, the baby is crawling around and exploring the exam room. That's good. Baby should be crawling by 13 months of age. So everything else looks normal. You just have a baby who's not walking at 13 months old, and that's totally fine. The range is 12 to 15 months, and so nothing is abnormal here. You can reassure the mother, follow up at 15 months. That's generally, you don't have to follow up at 15 months, but you can tell mom, if baby's not walking by 15 months, we'll take another look, maybe send over to a developmental pediatrician. No need for x-rays here. So here's your summary of important motor milestones. And we'll move on to question 19. So a 6-day-old newborn male presents with his mother complaining of bloody stools, which the mother says are maroon colored. This has been going on for the past couple days. There is no history of bleeding disorders in either mother or father's family. She's breastfeeding. Vitals are stable. On physical exam, you note a small amount of blood oozing from the umbilical site. There are no other abnormalities. BMP, liver function tests, CBC, plasma fibrinogen, and cranial sonography are all unremarkable. The PT is elevated, the PTT is mildly elevated, and bleeding time is normal. Which of the following is the most likely diagnosis in this patient? A. Von Willebrand's disease, B, hemophilia A, C, hemophilia B, D, hemorrhagic disease of the newborn, or E, deficiency of factors 2, 5, 7, and 10. All right, the answer here is D, hemorrhagic disease of the newborn. Now, this is not a common thing that we see anymore because we give vitamin K prophylactically to pretty much all infants when they're born. And so vitamin K, you don't get a lot in the breast milk, and vitamin K is also, you're helped in synthesizing that by intestinal flora, which you do not have very early on in life. It takes some time to develop that. And so hemorrhagic disease of the newborn, you're at risk for that if maybe for some reason you didn't get the vitamin K in the hospital or something like that. Again, pretty rare. But this is the laboratories are very consistent with vitamin K deficiency. And that's because we can rule out all these other things. So von Willebrand's disease, the bleeding time will be high. So in this case, the bleeding time is normal. And this is due to a deficiency of von Willebrand's disease, deficiency of von Willebrand's factor, which will increase the bleeding time. So that's important for platelet aggregation. Hemophilia A, typically there's a family, both hemophilia A and B. Typically there is a family history, usually on the mom's side, and it'll be things like uncles or grandpa. And with this, your PT will be normal. It's your PTT that's going to be elevated. And so in this case, we have an elevated PT and an elevated PTT. So this is not hemophilia A or B. Deficiency of factors 2, 5, 7, and 10 you will see in liver failure. And we have normal liver panels here. So that leaves hemorrhagic disease of the newborn. The PT is going to be high. The PTT can be normal, but it could be mildly elevated as well. And the bleeding time will be normal. And the bleeding time tells you that you have no problems with platelet aggregation. And that does not rely on vitamin K at all. So vitamin K deficiency in children and adults, it's typically manifested by a propensity to bleed. You'll see nosebleeds and bruises more commonly. Women often develop menorrhagia. In more severe cases, there can be GI bleeding or hematuria. In infants, you typically have vitamin K deficiency of the newborn. That's the diagnosis. The hemorrhagic symptoms include bleeding at the umbilical stump or circumcision site. And then remember always, anytime you have a baby with bleeding, to consider or just perform an intracranial sonography. So you have a baby with bleeding, very easy to do an intracranial sonography. It doesn't take long to learn how to do this. What you're doing is you're taking your sonogram, your detector, your probe, and you're looking at the baby's ventricles. It's very easy to see them. You're just looking for any fluid in those ventricles. And it'll be radiolucent, and you'll see bleeding. And in that case, straight to neurology they go. And that's due to usually when you have intracranial bleeding in the newborn and it's inside the ventricles, that's typically due to some kind of hypoxia that happened during birth, which affects the germinal matrix, which is highly vascularized, and you get bleeding into the ventricles. So that's not the case here. We did an intracranial sonogram, and that was normal. So at birth, vitamin K deficiency can be due to maternal medications, which include warfarin, phenobarbital, and phenytoin. So that could have been the case here. This is usually the reason that this happens because, like I said, we give vitamin K to pretty much all newborns when they're born. In the first 2 weeks of life, it's typically due to poor stores of vitamin K from inadequate transfer across the placenta, and then also it can be due to the fact that they don't get that vitamin K injection. And then 2 to 12 weeks of life, it's typically due to inadequate intake. If the child is breastfeeding, they're going to require either adequate maternal intake or vitamin K supplements. Formulas are generally fortified, so you don't need to get any kind of supplement. with that. Intramuscular vitamin K is administered prophylactically after birth to reduce the risk of such bleeding. So our workup is everything we did. Get a CBC, BMP, including liver enzymes, bleeding studies, PT, APTT. You suspect that there may be a possibility of hemophilia. If there's a history of bleeding disorders in the family, you can get factor levels. Plasma fibrinogen you should get also because there is a possibility of something like ITP or TTP, rarely, and then cranial sonography if you're dealing with an infant. Differential diagnosis is DIC, and in this case you'll have thrombocytopenia, elevated D-dimer. Typically this is going to be this is usually going to be in the setting of some kind of illness. So you may see sepsis, hemodynamic instability rarely. Liver failure, you tend to have elevated transaminases, and then hemophilia you should consider in older children who have an appropriate diet, no suspicion of malabsorption, which could affect their vitamin K absorption, or in patients who don't respond with oral vitamin K. And this can be easily diagnosed with factor levels. So you get the factor 8 and 9, you look at that, and if there's deficiency, then usually it's got to be less than 5 or 1% of normal, and you can diagnose hemophilia. And of course, family history always helps too. The diagnosis is based on the history and elevated PT that then resolves with administration of vitamin K. And please note that normal PT ranges by age, so the range varies, and you need to know that for clinical practice, but on the USMLE they will tell you if it's low or high or whatever, normal. So you don't need to memorize the ranges by age, that's not important. You'll be given all this laboratory information on the test. We'll finish with question 20. So a 15-year-old boy presents with his mother, who is complaining of a change in his sleeping pattern. She appears very concerned, which mother doesn't. Over the past several months, he's been staying up till 11 or 12 at night, and on the weekends he sleeps later, sometimes as late as 10 a.m. He is doing well in school and reports mild sleepiness in the morning, but none during the day. He is not on any medications and denies drug or alcohol use. Which of the following is the best course of action at this time? A, reassurance and sleep hygiene counseling. B, screen for depression. C, hydroxyzine orally. D, melatonin supplement. Or E, formal sleep study. All right, what is our answer to this question? Answer is reassurance and sleep hygiene counseling. So when you have a teenager and they're changing, they're developing, they're going through puberty, you tend to have these circadian shifts where they want to stay up later and sleep later. And this is not necessarily due to like some kind of behavioral issue. This is actually a physiologic change in their sleep pattern, and it generally goes back and returns to what we would consider normal as they get older. But this is a circadian shift that happens in adolescence, and this is totally normal. Now, it can be problematic if there are problems in school, if there's excessive daytime sleepiness, if it's leading to family issues or all those things. But if there are no significant sequelae, then we just consider this normal and we go about treating it very conservatively with behavioral changes. So reassurance, first of all, this is normal. You go through this during teenagehood. It'll eventually go away. And then also sleep hygiene counseling. And that's good advice for anybody. So we'll talk about sleep hygiene counseling on the next slide. But this is going to be your first step. Anytime you have a teenager with this circadian shift, which happens almost uniformly in adolescence. So screening for depression could be useful if you had a kid that maybe wasn't doing very well in school, had other signs of depression like depressed mood or changes in mood and behavior, maybe abusing drugs or alcohol. Then you could do a screen for depression, but that's not necessary in this case since we have a pretty cut and dry case where this is just a sleep pattern issue. Hydroxyzine. We could do that after we try sleep hygiene implementation. But this is just a antihistamine that can be used in very conservative therapy to help somebody sleep. But this is not going to be your first step. Melatonin supplement, again, something that you can do if sleep hygiene doesn't work. Formal sleep study. When would we do this? We would do this if the child, let's say, was getting 9 to 10 hours of sleep and still was tired during the day. So in that case, you're getting a normal amount of sleep, but the kid is still tired. And in that case, we're concerned about things like sleep apnea or something going on while the kid is sleeping, and we don't know it because the kid is sleeping. So you can't really report something going on if you're not conscious. And so you could do a formal sleep study, but only if all this other stuff above is not helping. Okay, so adolescents and sleep, there is a normal shift in sleeping pattern. They tend to be up later and want to wake up later. And so if you're up late, but you have to wake up to go to school, then you're not getting as much sleep. So let's look at this kid again, 11 to 12 o'clock at night. Typically kids wake up to go to school. Usually school starts around 8:30, some school districts at 7:30. So if he's up at 6 in the morning, he's only going to be getting 6 or 7 hours of sleep, and that is not enough. So that's probably going to explain the mild sleepiness in the morning. So adolescents require 8.5 to 9.5 hours of sleep per night. Usually 9 hours is what you tell them. So ideally, if he needs to wake up at 7:30 in the morning or 7 o'clock in the morning, then he should be going to bed at about 10 o'clock at night or getting into bed around 9:30 to fall asleep at 10 o'clock at night. So sleep hygiene is going to be our first step. And so with sleep hygiene, this is especially important now, even in comparison to 10, 20 years ago, because now we have cell phones, computers, a lot of kids have TVs in their room, but especially those cell phones. Kids usually sleep with them by their bed, and it's a distraction. So establish a bedtime routine. So sort of this ritual you do every night where you take a shower, maybe an hour before bed, hour and a half before bed, you brush your teeth, you clean your face, you get into bed, maybe read a little bit in dim light, and then you go to sleep. And make this a routine that you do this every single night. And this is all this sleep hygiene stuff. This pertains to adults with sleep issues too. Turn off all electronic devices within 1 hour of sleep. That includes TVs, that includes cell phones, iPads, anything electronically that emits lights. And it's not just because the electronic devices are stimulating and distracting, but it's also because they emit a blue light. And that blue light can actually affect your melatonin levels and can disrupt your sleep that way. No caffeine after lunch. So a lot of people drink caffeine, pop beverages, things like Coca-Cola, Mountain Dew. They'll drink that after they get home from school or at work or with their dinner. Don't do that. Cut off all caffeine after lunch. Now, some people can drink caffeine after lunch and go to sleep. That's fine. But if you're having sleep issues, cut off the caffeine after lunch because caffeine does stick around in your body for a while. Keep your weekend and weekday routines similar. That all goes back to that bedtime routine. It can be very difficult if you sleep until 10 a.m. on Sunday and you're going to bed then on Sunday night with the hopes of waking up well rested and getting 9 hours of sleep. It's going to be difficult to fall asleep if you just woke up at 10 a.m. Limit your naps to less than 30 minutes. That sort of helps with that circadian rhythm and that routine. And then avoid tobacco and alcohol, particularly alcohol. Alcohol disrupts your REM sleep. You get less REM sleep, and so you're going to feel less rested even though you're getting 8, 9, 10 hours of sleep. So with this, you do this sleep hygiene practice, do it for a month. If it's not working, particularly if the patient is having difficulty initiating sleep, you're doing all this stuff, yet you're laying in bed for 2 hours, not able to sleep, then go ahead and try the hydroxyzine. You can try the melatonin supplement, but just remember with a melatonin supplement, you need to start that, you need to take the pill usually about 4 to 6 hours before you plan on sleeping. With the hydroxyzine, you can usually take that 1 or 2 hours before you get into bed, but with the melatonin supplement, it's not a sleeping pill. You're trying to increase your melatonin, and so you need to take that quite a bit before you plan on going to bed. So maybe take it around dinner or a little bit before. Um, that's just general advice for a patient. And if this stuff doesn't work, then you can go ahead and do a formal sleep study. But remember, with the formal sleep study, we usually reserve that for patients who are getting enough sleep, but they're still tired during the day.